Dear ladies and gentlemen, my name is Stephan Achenbach, and it's my great pleasure to welcome you to the symposium jointly held by the European Society of Cardiology and APSC, the joint symposium called Pregnancy and Cardiovascular Disease. I'm very happy my co-chairman Wael Almahmeed from the United Arab Emirates, Abu Dhabi, is also here with me, and we have three fantastic speakers to touch these very, very important questions. And let me introduce, there are some housekeeping announcements that you can please use the live Q&A box to send your questions. And at the end of the session, after the three talks have been given, we will answer your questions, and hopefully as many of them as possible we will be able to answer live. So why don't we move ahead and call the first speaker, my good friend Bernard Iung from Paris in France. He will speak about the timing and the mode of delivery. And I'm really excited to hear this talk. Bernard, please.
Thank you very much, Stephan, for this kind introduction. It's my pleasure to be here with you to this joint APSC-ESC session dedicated to pregnancy in women with heart disease. I will address the timing and mode of delivery. I have no disclosure. Delivery and the peripartum period is a particularly high risk in women with underlying cardiac disease. As shown in the ROPAC registry led by the European Society of Cardiology, when considering maternal mortality during pregnancy, 2 cases occurred during delivery and 6 cases occurred during the first 2 weeks following delivery. Thus, 8 out of 3 deaths occurred during the delivery or the early postpartum period, highlighting the critical risk during this period. The risk of cardiac complications is related to the hemodynamic changes, which are physiological during pregnancy. And among them, the most important is the green curve, which shows an increase in cardiac output between 30 and 50%, which is maximum after the 5th month. And of course, this is a major hemodynamic stress, which can decompensate an underlying heart disease, even if it was previously well tolerated. Of course, these hemodynamic changes are further increased during delivery, and besides basal increase in cardiac output, we can see on this slide paroxysmal increase in cardiac output during uterine contractions, which may lead to doubling of cardiac output at the end of labor. Clearly, this explains the fact that delivery is at particularly high risk due to this considerable hemodynamic stress. Of interest, at the right part of the slides, I wish to insist on the fact that hemodynamic conditions remains impaired after delivery. I will refer several times in this talk to the last guidelines on the management of cardiovascular disease during pregnancy, which were released by the ESC in 2018. The risk of complication during the peripartum period is directly related to the severity of the underlying heart disease. ESC guidelines advise to use the modified WHO classification, which classified underlying heart disease according to maternal and fetal risk, as illustrated in the slides. The most severe cardiac conditions are those in class 3 or 4. The corresponding cardiac disease of these 2 classes are listed here. We will not detail them one by one, but rather classified it to summarize according to the most important cardiac categories. If we come back to the ROPAC registry, which now counts more than 5,000 women from 53 countries, we can see that the congenital heart disease account for the majority of structural heart disease encountered during pregnancy, followed by valvular heart disease, cardiomyopathies, and ischemic heart disease. And we will review these different categories. Of note, this distribution corresponds mainly to industrialized countries. In developing countries, valvular heart disease remains the most important heart disease encountered during pregnancy. Let's now begin with congenital heart disease. We can see here the condition which corresponds to WHO class 3 or 4, which are unrepaired cyanotic congenital heart disease, systemic right ventricle, even with preserved function, Fontan circulation, Eisenmenger syndrome, which is one of the more severe conditions, other complex congenital heart disease, and severe aortic recoarctation. With regards to valvular heart disease, stenotic valve disease carries the highest risk of cardiac complications during pregnancy, and among them, mitral stenosis is the worst tolerated valvular disease. It is mainly of rheumatic origin in young women, and as shown on the right part of the slides, it carries a high risk of decompensation, in particular during the last trimester, and it accounts for a significant contribution to peripartum morbidity and mortality. We can see on the right that the majority of women who were in NYHA class 1 at the beginning of pregnancy will subsequently deteriorate even in a severe condition in NYHA class 3 or 4. Aortic stenosis is more rare in young women, and the risk of decompensation is lower than in mitral stenosis, mainly during the peripartum period, as shown on the right part of the slide. Regurgitant valvular disease exposed to a much lower risk of cardiac decompensation during pregnancy, and in most cases have a favorable evolution under medical management. In women with heart valve prosthesis, there are specific problems which are not tolerated to hemodynamic tolerance, since it has been corrected by the intervention. But in case of mechanical heart valve prosthesis, there are different pitfalls which are related to increased thromboembolic risk for the mother and fetal risk, which may be related to oral anticoagulation. And this accounts for higher maternal and fetal risk, and particularly complex management of anticoagulant therapy, which will be detailed by Dr. Jolien Ross-Hesselink in the next talk. Hypertrophic cardiomyopathy is at risk only if it was poorly tolerated before pregnancy. Hypertrophic cardiomyopathy in women which were in NYHA class 1 or 4 or 2 before pregnancy, of course, require close follow-up, but do not have high risk of complication during the peripartum period. This is different for dilated cardiomyopathy, which is associated with a higher risk of complication, which is directly related to the severity of left ventricular dysfunction and clinical tolerance. A particular situation is the peripartum cardiomyopathy, in particular if a woman has experienced previous peripartum cardiomyopathy in a prior pregnancy and students with a residual left ventricular dysfunction. This exposes to a high risk of maternal mortality during a subsequent pregnancy. Ischemic heart disease is at relatively low risk if it is stable without residual ischemia and without residual left ventricular dysfunction during pregnancy. The most important risk related to ischemic heart disease is not surprisingly related to the occurrence of acute coronary syndrome during pregnancy. This is a high-risk condition in which may be increased due to delay in diagnosis and management, which are not rare in these conditions. When considering coronary heart disease during pregnancy, it is necessary to take into consideration certain specificities of ischemic heart disease during this period, which may be related to acute coronary syndromes in women with angiographically normal coronary arteries or spontaneous coronary artery dissection, which are at particularly high risk and may be prone to recurrence. Other cardiac conditions exposing to risk during pregnancy are aneurysms of ascending aorta, in particular if they are associated to a systemic disease such as Marfan syndrome or to bicuspid aortic valve. Pulmonary arterial hypertension has the same poor prognosis as Eisenmenger syndrome, and the risk of complication is highest during the peripartum period. Cardiac arrhythmias should be taken into account and also according to the underlying heart disease. Let's now examine the impact of cardiac conditions on the management during the peripartum period. Preterm delivery may be needed mainly in case of poor hemodynamic tolerance. In this case, the decision should be individualized by a multidisciplinary team and is always difficult and should balance the hemodynamic tolerance of the mother and the fetal maturation. Intrauterine growth is not rare in these conditions. A particular situation is the need for cardiac surgery during pregnancy. A prior delivery should be considered after 26 weeks due to the very high risk of fetal mortality when cardiac surgery is performed during pregnancy. These situations are particularly complex and should be managed in expert centers. Fortunately, most women with cardiac disease are in stable conditions and have few or no symptoms. And in this case, there is no reason to anticipate delivery. Induction of labor should be considered at 40 weeks in any case to limit the risk of complication, and vaginal delivery should be favored. It has been clearly shown that vaginal delivery is safe for the mother, provided heart disease is well tolerated and obstetrical conditions are favorable, and you see the corresponding recommendation in ESC guidelines below. It has also been shown, in particular in the ROPAC registry, that it is associated with a better fetal outcome than planned cesarean section. Indications of epidural anesthesia should be wide, and assisted delivery may be needed. The advantages of cesarean section are, of course, to suppress the hemodynamic stress due to uterine contractions. And so it clearly reduces the risk of cardiac complication in poorly tolerated underlying heart disease. Another advantage is that it allows for an optimal control of timing of delivery. Of course, cesarean section may also be needed for obstetrical indications. However, the counterpart of these advantages are an increased risk of thromboembolism, bleeding, and also the impact of anesthesia. If we wish to summarize the main indication for cesarean section according to the cardiac condition, these are mainly related to refractory heart failure, severe obstruction of left ventricular outflow tract, even when tolerance is good, aneurysm of ascending aorta, severe pulmonary arterial hypertension, isolated or in Eisenmenger syndrome, history of acute coronary syndromes, and labor onset under oral anticoagulant therapy. Of course, this situation should be individualized. With regards to anesthesia, epidural anesthesia is, of course, widely used to reduce labor pain, and this has also an impact on the hemodynamic stress. It may be used for cesarean section. However, the anesthesiologic teams should pay particular attention to the risk of systemic hypotension, which may be poorly tolerated in certain cardiopathies. A particular issue is the need of prolonged interruption of anticoagulant therapy, which may be harmful in women with a mechanical heart valve prosthesis. In certain cases, general anesthesia may be privileged for optimizing hemodynamic control, and hemodynamic monitoring may be also needed, And once again, this decision should be individualized in multidisciplinary teams. I wish to insist on the need for a particular awareness during the postpartum period. We have seen that hemodynamic remains impaired, and so it is needed to pay attention on cardiac symptoms, in particular during the first day following delivery. It is also necessary to be aware of the risk of postpartum bleeding, of thromboembolism. Drug therapy should be adapted, and later on, the underlying heart disease should be re-evaluated when hemodynamic conditions remain normal. In conclusion, delivery and early postpartum period has a particularly high risk in women who have severe underlying heart disease, and this should be assessed early in pregnancy, and afterwards close follow-up is needed for optimized risk stratification before delivery. The timing and mode of delivery should be anticipated and discussed by a multidisciplinary team according to the underlying heart disease and the tolerance during pregnancy. Vaginal delivery can be performed safely at normal term in most cases, provided tolerance is good during pregnancy and according to prepartum assessment at the end of last trimester. Cesarean section should be discussed in an individual basis, in particular in case of severe symptoms and in certain selected cardiac conditions. Once again, particular awareness remains needed during the postpartum period. Thank you for your attention.
Thank you very much, Professor Lung. That was an excellent presentation. Please keep your questions till the end of the third talk. We will be having a panel discussion. It gives me privilege to present our next speaker, who is a world expert on pregnancy and heart disease in pregnancy, Jolien Ross-Hesselink, who is professor of cardiology at Erasmus University in the Netherlands, and she will talk about anticoagulation during pregnancy.
Ladies and gentlemen, thank you very much for the invitation to present some data on anticoagulation in pregnant women with a prosthetic heart valve. I have no disclosures. However, I have to mention that together with Professor Vera Regit-Zagrosek from Berlin, I chaired the task force for the 2018 APSC guidelines for the management of cardiovascular disease during pregnancy. So why is pregnancy an issue? Well, it's not only accompanied by a hemodynamic impact with an increase in cardiac output of up to 40 to 50% and increased stroke volume and heart rate, but there's also a higher risk of thrombosis during pregnancy. In the APSC guidelines, we mention the modified WHO risk classification. Class 1 is no detectable increased risk, Class 2 is a small increased risk, Class 3 is high risk, and Class 4 is extremely high risk, meaning a contraindication for pregnancy. And in the guide are long lists with all the specific diagnoses of cardiac disease, and here you can see that for mechanical valves, the WHO classification is Class 3, so a mechanical valve is a high risk for pregnancy. This means that for these patients, expert counseling is required. The maternal cardiac event rate is between 20 and 30%, and the location of delivery of care for these patients should be an expert center for pregnancy and cardiac disease. What's also new in this is that we advise for every pregnant patient with some form of cardiac disease to consult the pregnancy heart team. This team should consist at least from an anesthetist, a cardiologist, and an obstetrician, but in case of a mechanical valve, also a hematologist and a lot of other specialists are absolutely needed. So now we go a little bit more in detail. Pregnancy, you are all aware of the Furcourt triads: circulatory stasis, endothelial injury, and hypercoagulable state. And these physiological changes of pregnancy induce this prothrombotic environment. So anticoagulation is of great importance during pregnancy. However, when a woman is treated for valve disease and is given a mechanical valve, anticoagulation should be used and is very important. On the other hand, you can also implant a tissue valve. This valve does not require anticoagulation, but this valve will deteriorate over time, and in most cases, somewhere between 10, 15, maybe 20 years, a new open heart surgery is required to replace the tissue valve. When a woman is treated with anticoagulation for mechanical valve, it's very difficult to discuss what to do with this regime during pregnancy. Of course, you want a good anticoagulation for the mother because the risks during pregnancy are higher, as discussed. On the other hand, you don't want adverse outcomes for the baby, and we do know that the use of vitamin K antagonists can be harmful for the baby. We know that when vitamin K antagonists are used during pregnancy, especially during week 6 to week 9, this may cause nose hypoplasia or chondrodysplasia in the child. And we also know that a higher risk is associated with a higher dose of vitamin K antagonists. This was one of the reasons to start the study on mechanical heart valves and pregnancy. And this was done in the ROPAC registry. This is a prospective registry, and we published this study in Circulation in 2015. The ROPAC registry is a prospective registry in which we included patients from 53 countries, and in total we nearly included 6,000 pregnancies. Had congenital heart disease, so over half. A quarter had valvular heart disease. We also included patients with cardiomyopathy, ischemic heart disease, aortic pathology, and pulmonary arterial hypertension. A sub-analysis done already a little bit earlier during the pregnancy registry, and this was based then, at that time, nearly 3,000 women were included, and of these 3,000, 212 had a mechanical valve, 134 had a tissue valve, and 2,600 had no prosthetic valve implanted. And of the women with a mechanical valve, 48 had an aortic valve, 130 a mitral valve, and you see the numbers for the aortic and mitral and pulmonary positions. So in this registry, a mechanical valve was typically implanted for patients with valvular heart disease, mainly rheumatic heart disease, while a tissue valve was typically implanted in congenital patients. For instance, in patients with a tetralogy of Fallot, a pulmonary homograft was given. And here you can see the diagnosis for the women with no prosthetic valve, but they all suffered from some form of cardiac disease. You can see the results for the complications, comparing the women with a mechanical valve compared to cardiac patients without a valve prosthesis. And you can clearly see that maternal mortality was much higher, 1.4% versus 0.2% in patients without a valve prosthesis. Thrombotic events occurred in 6%, hemorrhagic events in 23%, and the miscarriage rate was as high as 16% compared to under 2% for the non-mechanical valve patients. And also fetal mortality, so after 24 weeks of pregnancy, was still much higher in the patients with a mechanical valve. And if you plot that in this graph, you can see the mechanical valve resulting in a live birth of only 80%, while patients with a tissue valve or no prosthetic valve had a rate of about 96% live births. And then, of course, many had a complication. So in total, only 58% of the women with a mechanical valve had an uncomplicated pregnancy with a live child. So this is really a very poor outcome. If you look a little bit more in detail, how many had a mechanical valve thrombosis? Well, this occurred in 10 patients, and in 5, this occurred in the first trimester, and in all 5, this was during treatment. Here you can see a little bit more in detail the anticoagulation per trimester. So in the first trimester, up to 14 weeks, about a third had vitamin K antagonists, a little bit more had unfractionated heparin, and then also a lot of patients used low molecular weight heparins. And you have to see that also a few patients had no anticoagulation at all. But then during the second and third trimester, the majority was taken vitamin K antagonists, while only minor parts of the patients used some form of heparin. And then during the delivery, so the peripartum period, most patients were on unfractionated heparin. We also try to for specific regimes and see what was the outcome. And here you can see for the first trimester vitamin K, second trimester vitamin K or some form of heparins, and also the last period, the peripartum period. And you can see here that there really was a lot of difference between the use of anticoagulation over all the patients. There were guidelines for pregnancy and they advised these regimes. However, also other regimes were often used. So now what were the results when these regimes were used? This is plotted in this graph, but so first fetal mortality in relation to the anticoagulation in the first trimester, and you can clearly see that when vitamin K antagonists were used in the first trimester, the miscarriage rate was much higher, but also fetal mortality beyond 24 weeks of pregnancy was higher. And here you can see the complication rates for the specific regimes. On the right side you can see the regimes, and these are plotted in a specific color. So for the hemorrhagic events, we did not find many differences between the regimes, not statistically significant. Also for thrombotic events, maybe a little bit higher for vitamin K antagonists throughout, but this was not significant. However, if you look for live births, we really could see that there was a much lower percentage of women having a live baby. We also compared the women with the mechanical valve with the women with a tissue valve, and you can clearly see that there were more hospital admissions, more thrombotic events, hemorrhagic events, and a much higher miscarriage rate, also when adjusted for baseline characteristics. So the discussion, of course, is if a young woman needs a mechanical or tissue valve, I think you really have to take into account these results and perhaps choose for a tissue valve. However, you have to take into account that this is not a lifelong solution and that this woman will need another valve in later life. Also, the guidelines for anticoagulation are still not clear. You can see that many different regimes are used. And of course, the most optimal thing would be to do a randomized controlled trial. However, this is extremely difficult, not only because women don't want to take specific medication, but also doctors often have a very strong preference for a specific regime. Therefore, finally, there was a meta-analysis published in the European Heart Journal in 2017. And here the conclusion was that vitamin K are associated with fewest maternal complications, but also with the fewest live births. And sequential treatment does not eliminate anticoagulant-related fetal neonatal adverse outcomes. Low molecular weight heparin is associated with the highest numbers of live births, and the safety of unfractionated heparin and first trimester warfarin remains unconfirmed. These are the advised schemes for anticoagulation as published in the ESC guidelines of 2018. And here it is crucial to see that the doses needed for anticoagulation plays a role. So when the woman needs more than 5 milligrams per day of warfarin, then the advice is to switch in the first trimester to low molecular weight heparin and use during the second trimester or low molecular weight heparin or vitamin K antagonists. And the same scheme for women who needs less than 5 milligrams per day of warfarin, and here continuation of vitamin K antagonist in the first trimester is advised because the risk for fetal abnormalities, which occur typically during the 6th to the 9th week of pregnancy, do not occur when there is a change to low molecular weight heparins or when there is a low dose of vitamin K antagonist used. What about the delivery? In the new guidelines, it is advised that induction of labor should be considered at 40 weeks of gestation in all women with cardiac disease. Vaginal delivery is the first choice for the majority of patients, and indications for cesarean section are listed here. And of course, what is crucial for us is that when a woman is in preterm labor and still using oral anticoagulation, then this is an indication for cesarean section to prevent the baby to suffer from cerebral bleeding. In conclusion, pre-pregnancy counseling is crucial. You have to discuss with the mother and her partner the risks for the mother, the risks for the baby, and the specific anticoagulation regimes options. Preferably discuss in the pregnancy heart team pre-pregnancy and during pregnancy. The pregnancy should not exceed 40 weeks, and vaginal delivery is first choice in most women. Thank you very much for the attention.
Well, thank you very much for this interesting presentation. The next presentation will be on invasive procedures during pregnancy, and this presentation will be given by Rachel Cordina from Sydney, and we're very much looking forward to her talk.
Hello. For the next 15 minutes, I'm going to be talking to you about invasive procedures during pregnancy. So most of you would recognise that pregnancy is really a 9-month stress test. Cardiac output increases by around 50%, and that's driven by increases in stroke volume and heart rate. And pregnancy is also a prothrombotic and pro-arrhythmic event. So it's not surprising that this unmasks pre-existing cardiac issues, but it also predisposes to problems like myocardial infarction. And that's, of course, relevant for us today. Cardiac disease in pregnancy can relate to pre-existing issues, particularly congenital or acquired heart diseases such as rheumatic heart disease. They may be structural or rhythm related, or they may be pregnancy related, such as myocardial infarction. That's 3 times higher risk during pregnancy. And most series suggest that that's most often related to dissection, atherosclerosis and embolic events. In women who already go into pregnancy with heart disease, of course, we always like to meet a woman and optimise her before she becomes pregnant, but we don't always have that luxury. And it's the women in the WHO maternal risk class 3 and 4 who are at the most risk of requiring interventions. Problems like mechanical heart valves, severe valvular, particularly mitral stenosis, severe aortic dilatation. I've just listed here some of the more common issues that might arise where we would need to consider intervention, but one of the really cool things about doing maternal cardiology is that things crop up that you would never have imagined, and every case is a little bit different. So these are by no means a full list of problems that might arise. Heart failure or decompensation in the setting of severe valve dysfunction or outflow obstruction. Most often that occurs in the setting of severe mitral stenosis, and we might need to think about percutaneous valvuloplasty for mitral stenosis if it's suitable, or sometimes we'll need to think about urgent surgery. Uncontrolled arrhythmias may require an urgent ablation or even device implantation during pregnancy. Thromboembolic complications can occur, including valve thrombosis, and from time to time that will require urgent surgery. Aortic dissection is, of course, a potentially catastrophic problem that can arise during pregnancy, and myocardial infarction in some instances can be managed conservatively if it's spontaneous dissection, but in other situations angioplasty may be required. I want to tell you about 3 cases that have come up in my practice in the last couple of years, and while I'm speaking to you, have a think about how you and your unit might have managed these problems. There is no right answer. So of course, how you manage these women will depend on your centre's expertise. And so I don't at all mean to imply that what I did is absolutely the right way. So this first woman turned up to a hospital in rural Australia, very unwell. They thought she probably had influenza, but actually when we brought her down, it was clear she was in very severe pulmonary edema. She was 20 weeks pregnant. She had 2 living children and had had previous uncomplicated vaginal deliveries. She had a very dilated and impaired right ventricle and essentially systemic pulmonary pressures. And when I put the probe on her chest, I was quite surprised to find that she had a membrane in the left atrium. She actually had core triatriatum with an extremely high gradient. I was getting mean gradients of about 27, and when I calculated the orifice area, I was only getting about 0.4 centimetres squared, and I thought I must have made a mistake, but actually later on I was proven to be correct. The second case I want you to think about is a woman who turned up 6 weeks pregnant. She'd been lost to congenital heart follow-up for most of her life. She had a mechanical valve in the setting of an arterial switch for transposition of the great arteries. The pregnancy was accidental. She had anacrotic pulses, low pulse pressure. We were quite sure we were underestimating the degree of obstruction here at echo, where we were getting at least peak velocities of 4.3 meters per second. And the third case, it was a 30-year-old woman. She already had a 10-year-old son, and post that delivery had been found to have some kind of cardiomyopathy. She had a current ejection fraction of 10%, a subcutaneous ICD, and at 27 weeks, with an estimated fetal weight of 1 kilogram, she developed incessant VT despite maximal medical therapy. I'd like to tell you some general principles of what goes through my mind when I come across these kind of cases. First and foremost, the mother's safety is absolutely our first priority, but we need to balance up the risks to the fetus. Is there something we can do that minimises risk to mum, but we can try and get this baby through safely as well? Shared decision making is absolutely essential, both with the mother, her partner, and your colleagues. Multidisciplinary discussion is absolutely the core of all these cases. Emergency procedures are an emergency. They should not be delayed just because the woman is pregnant. If there is an option to safely delay, consider whether you can wait until the second trimester. There's a little bit of data and some guidelines suggest that might be the optimal timing, although I'll show you some data that doesn't completely support that. Or can we delay until we're at a viable stage for the fetus where we could deliver the fetus via cesarean section and then sort mum out quickly post-delivery? Always have a backup plan. Always think through what is the worst thing that could happen here. And not infrequently in these high-risk cases, I'll have small sheaths in the femoral arteries ready to go on to ECMO if needed. I sometimes will even have the ECMO team standing in the theatre while we're delivering. and consider the likely hemodynamic and hematological issues that are over and above what would happen in a non-pregnant woman. So remember, this lady already has high cardiac output. She may already have reduced reserve. She's in a prothrombotic state. So for example, if you're going to be putting in wires, do you need to anticoagulate in the setting of endovascular wires? And of course, we want to maintain placental blood pressure. So we need to make sure that mum does not have sustained periods of hypotension that could cause fetal death. Just some very broad anaesthetic considerations for cardiologists. Of course, our anaesthetic colleagues would find this very overly simplistic. There is no evidence that anaesthetic agents are teratogenic, but the anaesthetic agents can cross into the placenta, as can opioids, and can sedate the fetus. So we need to keep that in mind if we're going to be delivering the baby during these procedures. If the woman is approaching the end of the second trimester or third trimester, try not to have her completely flat on her back. Slight tilt is better so the IVC is not compressed. That will impede venous return and cardiac output. If the fetus is viable, a fetal heart rate monitoring before and after, and sometimes even during the procedure, is important. And we always try and maintain maternal blood pressure for the fetus. Some general principles about radiation. We try and minimize where possible, but I think often we get a little bit too worried about radiation exposure to the fetus. So when we can, echo or MRI without gadolinium is preferable. The threshold is unclear, but really the risk probably begins to increase at doses above 0.1 gray. So that is quite a high amount of radiation. So for permanent sterility, an adult would need about 5 gray radiation exposure. The maximum doses permitted for somebody that might be working with radiation is about 0.5 millisieverts per month. The maximum recommended gestational dose is about 5 millisieverts. But remember that 0.1 gray, that's where the risk starts to increase. And now I want to show you some of the doses that procedures we might consider during pregnancy require. So a chest X-ray is less than 0.01 milligray, so that's not gray. A CT coronary angiogram is about 1 milligray. So really these doses are, unless a woman's having repeated procedures, unlikely to be harmful to the fetus. We should not be not investigating mum just because she's pregnant. With regard to fluoroscopy in the cath lab, there's some simple things we can do. Usually the lead aprons aren't all that helpful, and in fact they're pretty cumbersome. Most of the fetal exposure is through scatter. So we try and reduce our fluoroscopy frame rate. We keep the intensifier as close as we can to the patient. Avoid angulated projections. Avoid cine. Fluorograb has much less radiation. Use the lowest possible frame rate you can. And of course, experienced operators tend to screen much less than your trainees would. And when possible, if you can avoid screening across the abdomen, for example, doing radial approach during coronary angiography, you will also expose the fetus to less radiation. Now, in terms of peri-procedural impact on the fetus, of course, doing cardiac surgery is about the most extreme thing we might need to do to a woman while she's pregnant. And Jolien's group published this very nice abstract, and I'm sure it's coming out soon as a full publication. In this meta-analysis of 328 women who required cardiac surgery during pregnancy, the fetal death rate was 7% in those who were able to have a cesarean and a premature delivery and then surgery. Fetal death rate was up to 1/3 in women who needed to have surgery with the fetus in utero. and gestational age was not associated with the risk for fetal death in the women who did require surgery with the fetus in utero. When we think about doing other non-obstetric operations, there was a really nice publication that was a retrospective cohort study in 6.5 million pregnancies. And these were really informative data. They found that the number of women for every 143 who need an operation during pregnancy, one of those women will miscarry. The risk for stillbirth is about 1 in 287. You'd need 39 pregnancies to have a low birth weight baby. The risk for maternal death, you can see there, is very low, but it's not zero. And interestingly, in these data as well, it didn't show that there was clearly a best time to do these operations. Perhaps you can see there, when we look at preterm delivery rates, that perhaps it's better to try to operate in the second rather than third trimester. But really, I think that it needs to be an individualised decision, working closely with your obstetric colleagues to decide on the optimal timing, depending on the situation. Management of myocardial infarction during pregnancy is generally similar to the non-pregnant state. Aspirin is safe throughout pregnancy. Heparin does not cross the placenta. Most centres these days will use drug-eluting stents rather than bare stents, even though their safety in neonates is not well established. And we try to use clopidogrel for the shortest time possible. And if we can, we prefer not to have it within 1 week of delivery because, of course, it increases the risk for postpartum hemorrhage. So back to my 3 cases I told you about. What did I do? So case 1, portary triatum, very severe pulmonary hypertension with diuresis, bed rest. I managed to get her to 32 weeks. And at 32 weeks, we delivered a healthy fetus. She had surgical repair at 3 months postpartum. Once we delivered the baby and had her optimised, there was no need for us to rush in and do the operation as soon as she delivered the baby. So usually, if I can, I like to try and let things settle, let the prothrombotic postpartum state, which hangs around for 6 to 12 weeks, settle before we do surgery. She's gone on to have 2 more pregnancies and she's doing very, very well. Case 2, the critically obstructed mechanical aortic valve, 5 weeks pregnant. This was a really difficult decision. This lady turned up, thankfully, in the very early days of pregnancy. And in the end, the thought of trying to carry her through with a very old, highly obstructed mechanical valve to some kind of, getting her to the 3rd trimester and then managing her off anticoagulation during labour really worried me, and I thought that was going to be very high risk. We knew if we operated at 5 to 6 weeks of the pregnancy, there was a significant risk that she might miscarry, but she was prepared to accept that risk because it was the safest option for her. And luckily, she didn't miscarry. The baby grew very well, and she recently has delivered a very healthy baby with a very uncomplicated pregnancy and had a normal vaginal delivery, didn't even need an epidural in the end. We didn't have time. She had a very rapidly progressing labour. And then the 3rd case, that certainly gave me a few grey hairs. So she developed incessant VT. She was 27 weeks. The fetus was around 1 kilogram. The stakes were high. She already had a little boy at home waiting for mum to come home. We decided to perform an urgent cesarean delivery at 27 weeks rather than try and do things like VT ablations where she could have gone into cardiogenic shock. We would have had sustained hypotension for the fetus. So we delivered the baby. As soon as the baby was delivered, the VT settled with medical therapy. She had over and under sensing of the ICD, so she did require an upgrade postpartum for her ICD. Because of the prothrombotic state, we anticoagulated for the first 8 weeks or so, so she didn't develop thrombosis on the leads. And she's doing well now on medical therapy and is not going to have another pregnancy. So in conclusion, invasive procedures during pregnancy carry risk for mother and fetus, but most of the time we can proceed with good outcome, but it does require very careful management and things can go terribly wrong, and it's absolutely awful when it does. Emergency procedures should not be delayed. A multidisciplinary experienced team is essential. Please don't hesitate to talk to as many experienced colleagues as you can to help you decide on the best way forward, because these decisions can be very complicated and it's tough sometimes. Thank you very much for listening.
Thank you very much, Rachel. That was an excellent talk. We're now open for the panel discussion. I don't see any questions here from the outside, so maybe I'll start with a few questions myself. Dr. Lung, with regards to in the community here, anybody who has a problem, a heart disease in pregnancy, tells the lady that she requires a C-section. It's very common. Anytime we see a patient, she's recommended to have a C-section. Can you please just describe which cardiac cases will require C-section?
This is an important issue, and we were facing a common issue in France decades ago, where indication for cesarean section were very wide in majority of women with a heart disease. We have now growing evidence, and in particular I cited the work drawn by the ROPAC registry, which showed that that vaginal delivery was feasible and safe in most cases when the situation is stable and the woman has few or no symptoms, and this is associated with a better fetal outcome. I just briefly address the most cases of cardiac disease which should lead to discuss cesarean section. Of course, the discussion should be individualized in a multidisciplinary team between cardiologists, obstetrician, and anesthesiologists, because all these practitioners should interact closely. The most frequent situation is poor hemodynamic tolerance, whatever the underlying cardiac disease. If the woman is in NYHA class 3 or 4 or has severe pulmonary hypertension, cesarean section is favored with close hemodynamic monitoring. In certain cases, even if the functional tolerance is good, certain particular heart disease represent indication of cesarean section. It is the case for aneurysm of ascending aorta above 45 millimeter in women with Marfan syndrome. The threshold is somewhat higher for bicuspid valve. If the woman has experienced previous acute coronary syndrome during pregnancy, in Eisenmenger syndrome or severe pulmonary arterial hypertension, this should be also individualized. A particular case, as has been shown by Dr. Cordina, is the need for cardiac surgery during pregnancy, where cesarean section should be considered before cardiac surgery if the fetus is viable. That is, of course, only a very short summary, and it is necessary to, of course, to individualize all this decision. But once again, I think we should not consider that cesarean section is the rule in any cardiac disease.
Fantastic. I would, for the practicing cardiologists, a question comes to mind, or a question that we frequently hear regarding arrhythmias in pregnant women. Number one is, which antiarrhythmic drugs can be considered for the treatment? And number two, a very practical question, what about cardioversion and defibrillation? What is the risk for the fetus? And maybe Rachel, you can enlighten us here.
So in terms of antiarrhythmics, if we were managing something like atrial fibrillation or flutter and we had to use an antiarrhythmic, I would usually favor sotalol over amiodarone, but we would need to monitor fetal heart rate. Sometimes we do need to use amiodarone. Ideally, if we did, we'd be introducing it towards the end of pregnancy and be needing to monitor the neonate's thyroid function post-delivery, because it can obviously affect thyroid function in the fetus as well. Cardioversion, there's really no significant risks, is my understanding, to the fetus for cardioversion, and often everybody's hopping around freaking out about it, whereas they should just stabilize the mother and cardiovert as quickly as possible and keep blood pressure to the placenta. Don't know what others' opinions are.
Yeah, sure. Jolien?
Yes, I would like to add, I completely agree with Rachel, and I think we have in the guidelines, we have information on what medication is safe, but most up to date are specific websites where you can find the most recent information on all antiarrhythmic drugs during pregnancy. And what is also of great interest is, can it be used during breastfeeding? Because last month we had a woman with ventricular tachycardia during pregnancy. They were benign, but well, they increased during pregnancy, and she was on flecainide, and it was successful during pregnancy, but she wanted to give breastfeeding, and it was quite difficult what to advise her, to not breastfeed or to stop the flecainide again. So finally, what we did is we did give flecainide, but we measured the level of flecainide both in the blood of the mother and in the breast milk and in the baby. And we did that up to 6 months of breastfeeding. And what we found is that the blood levels of the mother and also the levels in the breast milk were quite high, but the levels in the baby are very, very low. So I think it is safe to continue flecainide during breastfeeding.
Interesting considerations. The lady, Rachel, who underwent surgery and received the bioprosthetic valve during pregnancy, there is, of course, the question is, how do you anticoagulate a patient who has just received the bioprosthetic valve, even without pregnancy? There's some discussion about this, and what do you do? I mean, this is a very rare situation, but how did you handle this patient, and what is
so in general, in a woman that's not got a really fresh bioprosthetic valve, I would, and most guidelines would recommend just using aspirin. In her, because I was worried about the thrombosis risk early, I just used prophylactic Clexane doses for the first 8 weeks after she had the valve implanted, as well as aspirin. If we'd had problems with antepartum bleeding, I probably would have just backed off on the Clexane and continued aspirin. No evidence at all. And I think all of us who work in this area are often, there's no evidence for a lot of what we do, and things happen that you just, there's no trial for. But that was my approach. I'm not sure everybody would have approached it that way.
Interesting. You also mentioned the prothrombotic state of a pregnant woman. So that's another consideration for a freshly placed bioprosthetic valve. But obviously, it worked very well. And heparins
lucky.
Heparins are not a problem for the fetus. That's what I understand.
Correct. It won't cross the placenta.
We have a lot of people, again, in the community using low molecular weight heparin in pregnancy, but not monitoring anti-10A levels. Can you please discuss the use of anti-10A levels, and should it be peak or trough, and what are the levels?
Yeah, this is an ongoing discussion. I think it should be checked regularly, especially because during pregnancy, typically the weight of the patient goes up and you need a higher dose to have an effective treatment. So I really would advise to do the anti-10A levels. We do it once per week. Of course, this is quite often. I can imagine that it's not possible everywhere, but at least I would do the peak levels. These are proven to be of good value. We also do the trough levels, but there is no good evidence that this is helpful. So this is still a sort of expert opinion. This is not proven in a scientific way.
And Jolien, do you use trough level? I measure trough levels in women who are very high risk. I don't measure them in everybody. Is your practice, okay.
Yeah, we only do it for women with mechanical valve and really high risk patients.
Yeah.
and not for everybody.
Rachel, you mentioned about MRI without gadolinium. What's the issue with gadolinium in pregnancy?
We don't know. So I think that's the issue, is that we don't understand the long-term effects, and gadolinium has been shown to stay in the basal ganglia indefinitely, and we don't really understand what the impact might be in a developing brain. So I'm not an expert by any means, but my understanding is that if at all possible, we would avoid using that. But it's increasingly, fetal MRI now, sometimes in units they get worried about MRIing the mum, but, often now we're routinely doing MRI for fetuses as well. So I think we've gotten a lot more comfortable.
And there is some evidence that probably gadolinium is also safe, but I completely agree with Rachel. We don't have enough data yet, so we are a little bit reluctant to use it, especially in the first trimester.
A CT angiogram for ruling out pulmonary embolus is safe. We've also a number of patients in the community. We've seen this again, where the patients had query pulmonary embolus. They did not do a CT angiogram, so we're stuck. We don't know how to deal with these patients. Can you please comment on the safety? You showed it, but it's important, I think, to show how safe it is.
I mean, of course, you don't over-investigate a woman, and you do, but if something needs to be done and you have a high index of suspicion, something like a CT pulmonary angiogram, the risk for damaging the fetus is extremely low, unless she was going to need repeated CTs over that period. So when you look at the actual dose delivered, and even modern day CT coronary angiogram, if it's done properly and gated, again, if it needs to be done, it should be done.
Yes, I think you have two effects. So if you have a high dose in the first part of pregnancy, it could lead directly to congenital anomalies. And the other effect is more the stochastic effect. So if you have a lot of radiation during pregnancy, you have a higher risk of developing cancer in your later life. So of course we have to keep down the dose as much as possible, but if it is crucial to make a diagnosis, I would certainly advise to use it. I completely agree with Rachel in this.
And my understanding, the stochastic effect, that's just the same as if the child had been born. Whereas I think people think there's some magical thing because the fetus is inside, that it's extra vulnerable. But
yeah, I think you made an important point about the shielding. Whether it's during CT or during other invasive procedures, the radiation comes from the inside. It's the scatter radiation, so all the shielding really doesn't help very much. Yeah. If I may ask, if it's okay, a completely unrelated question to the to what we're currently discussing, and also, I'm a general cardiologist. I'm not specialized in this, but the situation that I sometimes encounter is the woman in a later stage of pregnancy who has heart failure, and the question is this a cardiomyopathy that she went into the pregnancy with, or is it peripartum cardiomyopathy? What are your thoughts regarding this situation? I don't know, maybe whoever feels compelled to answer, how do you proceed, and how do you manage one different from the other? Rachel.
I feel like I've talked too much.
Okay.
Briefly, so the history is very important. And if a woman's presenting in the first or, beginning of the second trimester, it's not going to be peripartum cardiomyopathy, even though often people think it might be. It's often very helpful. I know in the past I've been able to dig up ECGs from random hospital presentations and see that the person had a left bundle branch block 5 years ago, and little clues like that. Sometimes it's just impossible to be sure. If it gets better post-delivery or improves a lot, that's a little bit more suggestive of peripartum cardiomyopathy. Interested to hear what the others who are much more experienced than me think as well.
Anna, do you want to comment?
Anna, I think was getting ready to say something, but I'm not sure whether I interpret his movements correctly. Otherwise, maybe Jolien, you go first.
So I think that it's crucial to treat the heart failure as good as possible, and the underlying cause is not that important at that moment. You just have to give diuretics, of course, carefully, because you don't want to give a hypovolemia during pregnancy. You cannot use the ACE inhibitors or the ARBs, but nitrates, for instance, are safe, and sometimes you can use some beta blockers, low dose, which can cause some lower birth weights. But I think the condition of the mother is much more important than that side effect of beta blockers. So we do use that. Sometimes you even use the ECMO or other medication that's really needed. And after delivery, then you often see a very good recovery. So if the woman is in a bad condition, delivery is option one. I think, of course, when the fetus is viable, and if you have to wait, you have to wait. But I think often if you deliver the woman, she improves enormously. Mm. Of course, you can discuss the use of bromocriptine, which is still under discussion. It is now a 2B indication in the guidelines. But if you have a really severe case of heart failure and you think about peripartum cardiomyopathy, which often presents after delivery, then bromocriptine can be used, can be considered.
Bernard, you also wanted to provide some insight. I'm not entirely sure.
Just to support just what was said by Jolien, I fully agree with the therapeutic scheme, and in particular, that was also to mention that early delivery can be considered in this situation, can be needed. I briefly address this topic, and if the patient is an refractory heart failure, according to fetal growth and gestational age, early termination of pregnancy and early cesarean section should be considered. We had a recent case a couple of months ago in a patient who had underlying cardiomyopathy, which existed before. It was not peripartum cardiomyopathy, with severe functional mitral regurg, and who had a cesarean section at 29 weeks, and she dramatically improved after delivery. So it's clearly, once again, an integrated therapeutic approach combining medical therapy and timing and modalities of delivery, and subsequent evaluation afterwards.
Are there any specific consideration, again, around twin pregnancies, or even more than that, maybe in relationship to IVF, or is it just basically the same?
Oh, it makes me wish that the woman wasn't pregnant a bit more sometimes. It definitely increases the hemodynamic load. I had twins myself, so I'm speaking from firsthand experience as well. But it does.
I am a twin, but I can't tell what it means for me.
But it does, and in my past experience, women do tend to more easily decompensate. It's just a much bigger hemodynamic burden. Is that your experience?
Yes, well? I think twins is really a risk factor, and it's a risk factor for all kinds of outcome. And it clearly is an independent risk factor for prematurity and for for gestational age and for all fetal and neonatal complications. So it is an extra complication if you have twins. Absolutely.
On the subject of cardiomyopathies, whether peripartum or other cardiomyopathies, when we're always consulted, could the patient become pregnant again? When is it absolutely contraindicated?
When the ejection fraction is not normal again after pregnancy. So if you have still a diminished ventricular function, let's say 6 months after the delivery or 1 year after the delivery, then a new pregnancy is contraindicated. We often see a relapse.
Well, that's if you know that it's peripartum, but what if you don't know whether the patient went into the pregnancy, maybe already with cardiomyopathy?
Well, of course, then you have to discuss the risks with the mother and her partner, and you have to explain that you don't know what is the underlying cause. You can do genetic investigations. Sometimes you find myosin heavy chain mutation, then you're sure this is a dilated cardiomyopathy instead of a peripartum cardiomyopathy. We typically do an echo to see if the ejection fraction is very low or in between. We do an exercise test. This is very helpful in predicting who is at risk for developing complications during pregnancy. So if you're not able to perform, let's say 80% of expected, see how your heart rate is doing. These are very good predictors for the outcome for next pregnancy.
Jolien, if you had a woman whose ejection fraction had recovered to 45%, would you still counsel her against pregnancy if she hadn't been terribly unwell, or would you go into it if she was willing to accept that there was risk?
Well, I think my own opinion is a little bit changing over the time, because I was already much more relaxed than many of my male colleagues, and I already was very easy to go for pregnancy. But I think I've seen so many patients now, and often you can manage them. And I'm very much in favor of everybody who really wants to have children. We try to accommodate that. So I'm a little bit more reluctant than I was in the past, or less reluctant than I was in the past. So I talked to the mother and her partner. I discussed the risks. I explained that we don't know. There is no level A evidence available in this field. This is all expert opinion. And I discussed that there is a high risk that she has heart failure during pregnancy, but probably we can manage her. If it's really a bad ventricle, I really say no. But if it's about 45 to 50, I'm a little bit more relaxed.
Yeah.
Well, with that, I'd like to thank all our speakers, Professor Bernard Lang, Professor Rachel Cordina, and Jolien Ross-Hesselink, and my co-chair, Stephan Achenbach. I hope you enjoyed the session on cardiac diseases in pregnancy, and please enjoy the rest of the Asia Pacific Society meeting. Thank you very much.
Thank you.
Thank you.